Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, a look at the effectiveness of CPR, the gold standard technique when health professionals or members of the public are attempting to resuscitate someone in cardiac arrest. Stephanie Desmon talks to Dr. Demetris Yannopoulous, a resuscitation expert at the University of Minnesota, about efforts to improve outcomes by using a method that gives doctors more time to save their patients. Let's listen.
Demetris Yannopoulous, thanks so much for joining me.
Thank you so much for having me. It's a pleasure to be here.
So I have read with fascination about your work using a different form of CPR and testing it. And I'd like to start sort of with just a reminder to people what CPR is, what it's for, and how effective it is.
Very good. That's a wonderful question. CPR is what we call cardiopulmonary resuscitation. And the main purpose of the intervention, which is actually a medical intervention, it can be performed by lay person, by medics, by physicians, by nurses, is an intervention that takes over the function of the heart and the lungs. And effectively, it's what we all see in the movies or in shows where somebody's compressing somebody's chest, and that compression on the chest increases the pressure inside the chest, like squeezing a toothpaste, and so it pushes the blood out towards the brain and the rest of the organs. And during the decompression phase, allows the chest to fill back up with blood, and basically that repetitive motion replicates the heart pumping. Now, we also focus on giving oxygen. Circulation is there to give oxygen, and by giving ventilations, the respiratory part of the CPR is there to exchange gases that are basically the most important thing to sustain a life. And CPR itself is deployed when somebody's heart stops. So when the heart stops, you have very few minutes that can stay without blood and oxygen going to your brain. And usually those vary from 5 to maximum 7, 8 minutes without permanent damage. But once somebody falls down and the heart stops, then CPR is the first thing that needs to happen. And the earlier we initiate CPR to replicate the function of the heart and the lungs and perfuse the brain, the longer we have to basically allow the patient to come back and maintain back its own cardiac function. That can be achieved subsequently by defibrillation, the shocks that you see many times on the TV, or by medications, depending on the type of cardiac arrest that exists. Now, I want to clarify that cardiac arrest is not the same as a heart attack. Cardiac arrest is when the heart stops. We have 3 types of cardiac arrest. One is when the heart electrical activity goes berserk and creates a chaotic electrical signal, and those are called the shockable rhythms. We have another type where the electrical activity of the heart is organized, but the mechanical function of the heart fails completely, and that is called PEA, or pulseless electrical activity. And finally, the most detrimental of all is called asystole, which is neither mechanical function is present nor electrical activity is present. And those are usually the worst outcomes and mostly delayed cardiac arrest that we observe in the streets and in the hospitals. So cardiac arrest can be caused by a lot of things, electrical problems, coronary artery disease, blocked arteries. And it can also be caused by trauma, electrolyte abnormalities, and all the other things that it's a big list. So cardiac arrest survival depends on 3 very important things. Early detection by hopefully bystanders or family members, activation of the emergency response system, and immediate implementation of CPR where the patient is. So CPR is extremely important because it allows you to buy time to bring back the heart. Without it, you are most definitely dead. CPR, although it's not very effective as your heart pumping and produces usually 20 to 30% of overall blood flow compared to your heart, which also decreases over time and becomes insignificant after 20, 25 minutes, is paramount in the chain of survival for people that suffer this catastrophic and very rapid and sudden lethal event.
So it's vital to survival, but for example, in an ER, it's rare for CPR to revive someone.
Yes, so overall survival, if you take the whole population of cardiac arrest and you deploy what we currently do, which is 911 call, do CPR, give some medications, and when in a quarter of the cases you can shock a patient out of a bad rhythm, provides a survival rate of about 10% overall in the United States. That tells you that that process itself is very inefficient. When it comes to the shockable rhythms, the ones that have electrical instability, the survival rate is about 25 to 30% in the best EMS agency. So 1 in 3 of these people will survive. The survival rate for the other two situations are grim, in the single digits or 0% for asystolic patients, close to less than 1% most of the time. So that tells you that what we currently do, although it's better than nothing, it's not very efficient. And it's true, the more time you spend doing CPR, the less likely you are to survive. And we have found out with thousands and thousands of patients and data and collection and history and all these things, we have found out that CPR itself, as it's performed, reaches a single-digit survival rate within 20 minutes to 30 minutes for the shockable rhythms, and within 10 or 12 minutes in the non-shockable rhythms. After this period will become so futile, is there anything we can do, or should we stop? If you look at the overall response of EMS personnel and how they treat cardiac arrest in the field, the average duration of people trying to revive somebody is about 28 minutes for patients that have shockable rhythms, because their experience and the data suggests that just continuing further, it's kind of futile.
So you want to give people more time, right? I mean, that's the key. So you have a different kind of CPR.
So I'll try to make this as simple as possible. The reason that people don't usually come back over time is because of two fundamental factors. One is that as time goes by and you're not meeting the oxygen requirements of the tissues, the body becomes more acidotic. Like when you run and get cramps in your muscles, the muscle is not going to work, right? So that gets progressively worse because you cannot exchange all the oxygen that you need to maintain viability in your body. So there is a threshold below which the drugs don't work and your muscles and your heart cannot restart again because the metabolic milieu around it, the conditions under which you basically operate, are not favorable to start the normal physiological process of a heart beating and circulation to be established. The second thing is sometimes, and very commonly in patients with shockable rhythms, the heart cannot be started because the reason it stopped was a heart attack. And about 70% of the people cannot get initially pulses back with shockable rhythms, have blocked arteries. And they have a lot of blocked arteries, and usually major arteries are blocked. Although you are doing CPR, blood doesn't go to the place that will allow to replenish the oxygen in the heart to start its function again. So because we have inefficient production of circulation and also blocked arteries or other causes that cannot be identified early on, that cannot be reversed with CPR, you end up dying. So the new process that we implemented is basically a simple idea. It's not really rocket science, to be honest with you, but it's easy in its concept and very difficult in implementation of it. The concept is that since technology exists, and this is the ECMO machine, and I'll tell you what ECMO machine is. It's a machine that can produce oxygenated blood and create pressures inside the heart and take over the function of the heart and the lung. We can implement that at a point where CPR becomes inefficient, reverse the metabolic problems, perfuse the brains, the heart, and the organs, and then allows the physicians the privilege of having extra time to try and identify reversible causes and reverse those causes, which is the fundamental principle of medicine from Hippocratic times, to allow for the heart to restart and they allow for the organs to heal while all the function is supported by a machine that does the job that initially the heart and the lungs should do. And that process has some technical complexities and also organizational complexities. But the fundamental machine that we use is called the ECMO machine, which stands for extracorporeal, which means outside the body, membrane oxygenation. And effectively what it is, it's some very large tubes that you'll be scared to see going into your body, go all the way from your leg all the way up to your right and your heart in your venous system, sucking all the blood out, putting it through a little pump that pushes it through a membrane that carries oxygen and can exchange oxygen from carbon dioxide and then pass it through the arterial side of your leg all the way to go up your aorta and perfuse the rest of your body. By doing so, also pressurizes your system and creates your blood pressure. So effectively, it's the same process that we use when we arrest the heart to do a bypass surgery or valve surgery or heart transplants. Effectively, it's the same machine, but miniaturized and in a way to be able to perform in a more complex environments than in an operating room. So that process is also a very time-sensitive process. We call it ECPR, extracorporeal cardiopulmonary resuscitation, because it uses ECMO instead of just compression of the chest and ventilations in the mouth, in the airway. Once you have somebody on ECMO, which takes some time to put on, in expert hands can take from 3 to 7 minutes. Less expert hands can take up to an hour to place somebody on that. So you can see that the expertise play a big role in this. Once you are on ECMO, then your body is basically alive. And you perfuse and you give all the oxygen at once. So then the rest of the question, which is, what is the window that this therapy can be applied and how efficacious the process is to save lives? And that, I would say, is, again, not a very difficult question to answer. I think we know the answers for now, but it has very complicated infrastructural and logistical issues that need to be addressed, either with technology or with rearrangement of emergency medical services providing those therapies.
And you've been really successful at your medical center with ECPR. And I understand that others have not been as successful when they have tested this. First of all, it's very expensive, so you need to have all the machines in place. But also, I understand you are very, very skilled at performing this, and not everybody is going to be, especially when they've never done it before.
I will not be able to comment on my skills, but what I would say is the skill sets required for something like this are manifold. The technical skills for starting what we call CPR can be found or can be taught to a lot of people with certain skills in our medical profession. I think what is very complicated is the commitment that the team members have to have in order to be responsive in a very short time interval. So the way the healthcare system is performing ECPR in our Minneapolis-St. Paul area is that we have a team of about 5 physicians that I personally kind of trained for years with my colleague Jason Bartos, who is also a very, very experienced ECPR expert. And every medic that sees a cardiac arrest in the field with some specific criteria that we use calls a number, and we are able to respond within 10 or 12 minutes to the closest hospital or reverse everything that we're doing in the hospital and allow the patient to come directly to a cath lab, for example. But for that skill, we have to be basically on call for that to happen. And that is a very hard thing to do for the majority of physicians. The problem is the more people you have, the fewer cases you do, the less confident you are and less skills you have. The more you want to do, that means you have to take a lot of call. So the procedure currently requires this kind of involvement, personal involvement. But our goal was to show that this therapy works. For me, for example, I have an emergency response vehicle, so I had to learn how to drive like a police, like a state trooper with sirens and lights. And in the middle of the snowstorm, it's not always the most pleasant thing to do, and it's very scary. You also know how to know communications, the radio communications, and talking and meeting the demands of different EMS agencies on cell phone communications, radio communications, computer communications. To creates a little bit of, requires people that are okay to perform very accurate procedures and very accurate interventions in a chaotic environment. And that's not for everybody. There are certainly people that can do that, but they need to be self-identified and basically trained. So I think that is the fundamental complexity of the system that we have. And the most sensitive, the underbelly of all this is the current EMS and health politics that exist, because it requires healthcare collaboration and not competition for something like this to happen and be successful. The amount of cases that we do every year, if they split among 15 hospitals, will lead to very few cases in each hospital, and then the system cannot really address them appropriately. To have a centralized team that serves physicians from different healthcare systems like we did, and having the ability to go to different hospitals, bill for the services there, and collaborate rather than being aggressive with each other in the market of the healthcare systems, allows for this to be successful and creates enough volume and experience that lead to better outcomes.
So one last question I have before we go. Part of me wonders why this isn't everywhere, but I think we sort of addressed that at this point. But what's the best way to get eCPR to more people?
Yeah, so that is a wonderful question. I think I cannot tell you I see the future, but I'm working for a future that I believe it's more democratizing, makes the procedure a little bit easier. So the way I see this to happen is an intermediate step where the procedure and the technology becomes much easier to handle, much easier to start early, even if it's less efficient than the overall big system. Light technology, small access points that support the patient until they can reach a hospital. In that way, you can either train a vast majority of specialized medics or physicians that take shifts with their own, like EMS physicians, that know how to do that, and they dispatch for certain cases. They place the ECMO at the site, but they place it in a much simpler way that provides maybe less support than the full system, but buys you time to basically extend the period where you can be survivable and then address the problems in the hospital subsequently when the whole team, surgeons and cardiologists, are all available to go all on board.
This has been fascinating. Demetris Yannopoulous, thanks so much for joining me.
Thank you so much. It's a pleasure. Thanks, Stephanie.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.